Hi, my name is Connie Laclanders and you're watching the video titled Principles of Managing Neurogenic Palsies. In this video, we'll be discussing overarching principles when we're managing a patient who presents to us with a neurogenic palsy. And we'll be talking about principles in relation to non-surgical management and also surgical management of patients with neurogenic palsies. Okay, before we discuss the options we have in relation to managing these patients, we first have to have an understanding of recovery in relation to neurogenic palsies. Now, patients with an acquired neurogenic palsy show some spontaneous recovery over time. And it's during this period that we particularly want to manage the patient with non-surgical treatment options. So during this waiting period, a number of things can happen. One is that there could be complete spontaneous recovery of the neurogenic palsy. So say for instance you have a sixth nerve palsy, you have limited abduction, the development of a muscle sequelae. You could also in the 6 months or perhaps longer, 8 to 9, maybe 12 months, have a spontaneous recovery of that sixth nerve palsy such that you return to, or the patient returns to having full normal ocular movements, no deviation in prime position and no complaints of diplopia. The other possibility is that you have partial recovery. So that sixth nerve palsy, as an example, may recover but not fully, in which case you still may have limited abduction, you still may have diplopia, you still may have a deviation in prime position, and in this instance, depending on how much recovery has occurred, surgical intervention may be required. The other possibility is that it remains unchanged, there is no recovery at all, it's relatively stable. And the last is that it could be a worsening condition, in which case we're seeing that the strabismus gets worse over time. So it's imperative that when you diagnose a recently acquired neurogenic palsy, that you wait at minimum 6 months to see what category this patient will fall into, whether they'll recover fully or partially, whether they'll be stable, whether they'll worsen. And should there still be change at 6 months, you need to wait beyond 6 months before you go down the road of any surgical intervention. So during the period where you're monitoring the patient to see whether recovery does occur or to see whether the patient stabilises and so forth, you will need to be monitoring the patient's deviation, and you'll need repeatable comparable measures between visits. So you'll have a select or a series of clinical investigations you're performing on every visit so that you can have a record of improvement. And the types of things that, the types of assessments that can show you those sorts of improvements or change over time are the measurements of the deviation using either, for instance, the Prism cover test or the synoptiform. You will have a Hess chart, field of BSV, etc. So these are not the only tests that I've listed here that you can utilise for monitoring the patient. These are just an example of how they're measurements that specifically can show you any change that's occurred over time. You'll also have, for instance, your cover test, you'll have your ocular movements and showing numerically the limitation, whether there's any improvement. It might go from -3 to -2, for instance. So there's a series of investigations, but the ones I've listed here are perhaps a little bit easier to notice that, okay, in prime position the deviation was 30 diopters at visit 1, at visit 2 it's 20 diopters, at visit 3 it's 15 diopters, etc. So you have this series of clinical tests that are more clearly indicating that there is change and there is a reduction in or improvement in the neurogenic palsy, as an example. Okay, let's move on to non-surgical management of patients, and here I've given you an image of Hillary Clinton, who was given a frontal prism over her left eye. You may recall that in 2013 she had a fall, she fainted and had a concussion, and she developed double vision after that point. I'm not sure exactly what her clinical diagnosis is. I believe she may have had a left sixth nerve palsy, a relatively minor palsy with some abduction limitations or diplopia. I don't have any confirmation of that, but clearly we can see here that she was complaining of double vision and had a frame given to her to as a temporary measure to alleviate diplopia. Okay, so in terms of non-surgical methods for the treatment, this is utilised mostly during the monitoring phase of the neurogenic palsy. So in that first 6 months, whilst you're waiting to see whether the deviation improves or not, what we want to do is alleviate the symptoms of the patient, and the most troublesome symptom that the patients will present with is diplopia. So we'll be managing their diplopia during this time. The other thing that will happen during this period is obviously if there is another health condition that relates to the neurogenic palsy, for instance, if you have a diabetic patient that's been diagnosed upon having a neurogenic palsy or another systemic condition, they will need to have that also treated by the appropriate medical practitioners. So clearly this may require a referral to other medical practitioners depending on what the condition is. In terms of non-surgical orthoptic management, as I just mentioned, it will be usually for diplopia, and where a patient doesn't have troublesome diplopia, and this will occur either if they've got, say for instance, extremely reduced vision in one eye, in which case they may not notice diplopia, or sometimes when there's large deviations, the diplopic image is so far away that the patient may not actually complain or find that the diplopia is troublesome. So in instances like those, for example, where the patient isn't having troublesome symptoms, then simply what we'll be doing is monitoring the patient from visit to visit and looking for change in the neurogenic palsy. However, where we're going to manage the diplopia, there are a couple of options we have. Firstly, we can look at head position, in which case we can assist them with adopting an abnormal head posture or teaching them around how to use their head to avoid diplopia. We can also prescribe Prism, so you could prescribe Occlusion, you could prescribe Orthoptics, which is exercises in this instance, and the other option also is to inject Botox into one of the extraocular muscles. Now, before we go through each of those options, I just want to reiterate at this point that diplopia can be a very troublesome symptom for a patient and can affect one's ability to undertake day-to-day activities. And so it's important that you, as the orthoptist who's managing the double vision, explain the symptom, explain what's going on, reassure them, and also explain to them or inform them about the possibility of spontaneous recovery, and also the options of what would happen if there is no spontaneous recovery. Obviously, you're going to be working with a surgeon, so they will also contribute further to any surgical options, but you need to also be involved in the education of the patient in relation to diplopia and the strabismus that the patient has, and be very reassuring and assisting during this phase, as it is quite a difficult symptom to deal with, and they're very appreciative when you're able to assist them in terms of alleviating their diplopia and assisting them to regain normal function. Okay, let's start with abnormal head posture. Now, most patients will come to you with an abnormal head posture if it is possible for them to gain BSV. So you're generally not needing to assist a patient to adopt an abnormal head posture, but it may be an instance where you may need to do this, and it may be a simple solution of turning the head to the right or left to attain BSV. So this is one option that you could teach a patient. The other is that sometimes a patient will come to you, they may have no deviation in primary position and BSV in primary, but they may complain that when they look over to the right, there is diplopia, as an example. Now, in this particular instance, if it's in the periphery and obviously not in primary position, you could actually teach the patient to, rather than look to the right, that they turn their head when they're looking to the right, in which case they maintain their eyes relatively in primary position and therefore don't actually need to abduct the eye or abduct the right eye and abduct the left eye, which is what is potentially, or one of those muscles is potentially causing the issue in right gaze. So teaching the patient to move their head rather than their eyes can also assist the patient where they have deviations in the periphery, and often that's all they need and no further treatment may be required, particularly if it's in a position of extreme gaze. Some patients may not even need treatment if it is in extreme gaze as well. Okay, moving on to prisms. We generally prescribe frenal prisms, so the prisms that we can actually put on glasses. And the reason we do this is because we're usually prescribing prisms during the recovery phase, or the phase where we're watching or monitoring for recovery. And as such, what you may find is that the deviation is changing and you need to change the size of the prism. And it's very costly to ground prisms into glasses, and if you're doing this every 8 weeks for quite some time, it can be very costly for the patient. So putting a frenal onto the lenses is a far better option during periods where the patient is recovering. If, however, your past recovery, the patient is stable and you're looking at a permanent solution using prisms, you can then consider grounding them into the lenses. In prescribing prisms, what we want to achieve is comfortable binocular single vision at minimum in primary position. So you will recall that patients with incompetent strabismus will have a deviation that changes depending on position of gaze, and as such, at times it's not possible to provide a patient with a prism that will alleviate diplopia in all positions of gaze. So this is why we say at minimum you want BSV in primary position. You will need to also ask patients about what their needs are or their daily needs are. For instance, if they have a job where they're consistently in down gaze, alleviating BSV only in primary position may not be an option. You may need to give them something for down gaze as well as for primary position, as an example. Okay, looking at frenal prisms, there's a couple of options we have when we prescribe them. One is to give a complete frenal. So when the image I showed you earlier of Hillary Clinton, she had a complete frenal where the frenal takes over the entire lens. The other option is to provide a sector prism, in which case what you're doing is you're including the frenal in only part of the lens. And if we look over to the right here, we can see a patient here who's been given a frenal that's been only placed in part of the lens. So in this instance, when the patient looks over to the right, we're alleviating diplopia in this position. We can see that the visual axis here is free. In other words, most likely this patient actually has BSV in primary position. This is not their position of complaint. They're complaining of double vision to the right, and so a frenal has been given, but it's a sector frenal that deals with the diplopia in a specific position of gaze. The other thing you can do is provide a segmented frenal, in which case you're dealing with putting them in a section of the glasses, such as the bifocal segment of the glasses. Now, to determine the strength of prism to prescribe a patient, we use a prism subjective. So in clinic, you would do a prism subjective. So take your prism bar and increase it in strength until the patient tells you the first prism by which they achieve BSV. Now, you want to give them comfortable BSV, so you want to make sure that that first time that they indicate they have BSV, that is a comfortable prism. You may need to go another one up to compare between the first time they have BSV and so forth. But what you want to do is give them the least amount of prism possible. The greater the frenal is, the more degraded the visual acuity will be. And also the least amount of prism you give will provide them with an opportunity to perhaps utilise their fusional vergences to take care of the remainder of the deviation. Now, where there is a combination of a vertical deviation and a horizontal, you always treat the vertical deviation first. So what you need to do is, when you're doing a prism subjective, correct the vertical deviation first. Now, the reason we do this is because vertical deviations are more disruptive to BSV or fusion than horizontal. And sometimes if the horizontal deviation isn't great in size, if you correct the vertical component, that may be sufficient for the patient to then take control of the horizontal component of deviation. So what you want to do is correct the vertical, see if this is sufficient for the patient to gain BSV, and if not, then introduce the horizontal prism. Okay, and then you're prescribing a combination of a horizontal and a vertical prism. Okay, generally if you've only got a horizontal prism, you're not going to need the full prism to correct the deviation. So say a patient is 35 diopter ET, generally you're not going to be required to prescribe a 35 diopter base out prism. You can theoretically, usually, only require about 2/3 of the full PCT correction. But again, what you'll be going by is the prism subjective and the patient's response to when they have comfortable BSV. But you will know you won't need that entire 35, generally speaking, in most instances. Now, in terms of which eye do you place the frenal in front of, because you're going to be reducing the visual acuity with the frenal often by a line or two, depending on the strength of the prism you prescribe, what we generally do is put it in front of the eye that has the lower visual acuity, if there is one that has the lower visual acuity. At the end of the day, the outcome is relatively the same, so you can also let the patient choose which eye they have, or they'd like to have the frenal put in front of if there's a preference on their part, as it really doesn't matter in terms of which eye you put it in front of, even if it is the deviating eye or not the deviating eye. Okay, just a reminder that with frenal prisms you can use the nomograph, which is available or provided by the Frenal Prism and Lens company who makes the frenal prisms. And you use this where you're going to prescribe a vertical and horizontal prism. You can use the nomograph to determine the strength of the frenal that you need and the prism rotation angle required so that you can achieve BSV with a single frenal rather than prescribing one vertical and one horizontal frenal. And below here is the nomograph available on the LMS, which you would be utilising to work out the angle at which to put the frenal to achieve BSV. Now, in terms of how successful your prescribing of prisms will be, or frenals, it will be determined by the degree of incompetence. And you can imagine that the greater the incompetency, so the greater the change of the deviation dependent on position of gaze, the more difficult it is for you to give the patient BSV or comfortable BSV in a number of positions. So if the patient requires different strengths for near and far, if the patient requires different strengths for primary, down, right, left gaze, etc., you could have issues in being successful in prescribing the frenal prisms, or for the patient to feel that there's been an alleviation of their symptoms, or to be happy from the prescribing of prisms. Where you might have differences between near and far, you can look at prescribing frenals for a near pair and prescribing frenals for a distance pair, for instance. You can look at providing bifocal segmented frenals. So look at the options you have when you are presented with patients with various differences in the size of the deviation. Okay. In terms of the patients who are most successful with frenals, it is patients with less than 10 diopters of deviation will generally have extremely effective relief of diplopia through frenals. Okay. The larger you get, the more difficult it will be for you to alleviate the diplopia. Now, before we move on from frenals, I just want to reiterate the point that frenals are a very good option whilst patients may be improving or whilst you're monitoring for spontaneous recovery. And they're also useful in trialling what you may end up grounding into the lenses. So before you go to the expense of prescribing a permanent prism in the glasses, frenals are a great way to determine if the patient will be happy with the prism that you prescribe in the grounded lens. Okay, the other thing you will have an issue with is patients who don't have glasses. So where a patient presents to you with a recently acquired neurogenic palsy and you want to prescribe frenals, if they've never worn glasses and they don't have a refractive error, then you don't have a pair of glasses to put the frenal on. Now, in these instances, because you know it's a temporary measure, you can suggest that patients simply buy some 0.5 lenses from the chemist so that you can put a Fresnel on those. They can also obviously buy a pair of glasses that are Plano, either from an optical store or online, etc., so that there are options for the patients depending on how much they want to spend. But because it is a temporary measure, you don't want to be spending a lot of money on a pair of glasses that the patient knows they won't need beyond a certain period of time, or is unlikely to need beyond a certain period of time. Now let's move on to occlusion. Now you can obviously prescribe occlusion to alleviate diplopia. And here I've given you the famous patch from Days of Our Lives, which I'm not sure any of you are old enough to remember. But there you go. I don't know why he was wearing a patch, but certainly you can prescribe a patch for the alleviation of troubles of diplopia. Now, this is not a preferred option as compared to Fresnels or utilisation of head postures, because you're taking away a patient's BSV. You're making a monocular effectively. So if you can attain BS3 through the use of prisms, or if you can attain BSV through a head posture, that's probably a preferable option than moving into occlusion. But obviously, should these two options not be available to you, and generally this will happen when the deviation is very large, incommodant, the patient requires a very uncomfortable abnormal head posture, or you're unable to find a prism that makes the patient happy and gives them BSV, then we will move to occlusion. Generally, we indicate to the patients to wear it as necessary. They don't need to wear it 24/7. And there is debate as to whether you ask the patient to occlude the paretic eye or the non-paretic eye, the affected or the non-affected eye. I don't think there's any good evidence to indicate one way or the other, but often the patient elects to cover the affected eye, which has the limited eye movement. Another option is also occlusive contact lenses. These can be prescribed to alleviate troublesome diplopia. This is generally given to people who might be concerned about the cosmetic appearance of having a patch either on their eye, over their glasses, etc. The occlusive contact lens obviously will not be noticeable or as noticeable to the general community. Okay, the other note I have here over to the right is that where you have a young child during the critical period with an incommodant strabismus, you're also concerned about the development of amblyopia, in which case occlusion will be prescribed for this purpose as well. So just bear that in mind when you have your younger children with incommodant strabismus. Okay, in terms of your options, there are a variety of options that you can utilise. Most of these we've discussed in concomitant strabismus, so I don't need to go over in any detail, but I've shown you here that you can use a full occlusion where you totally occlude the eye, and you can use things like an eye patch or a pyro patch, maybe if you're more familiar with, an adhesive patch, and this is just one particular type of adhesive patch. There's a number on the market, and for young kids we often prescribe those which are a little bit more fun and have pictures and so forth on. You can prescribe partial occlusion, in which case you're allowing some light entering into the eye, but it's sufficient enough that it's degraded the vision in such a way that the patient can now ignore the diplopic image or doesn't see the diplopic image. So here we have the min occlusion lens, which is produced by Fresnel, Prism and Lensco, and you can see here that the left lens is opaque. It's actually a lens like the Fresnel, which is put onto the lenses of the glasses and degrade the vision, and it degrades it to less than 660 VA. So that's an option for some of your patients. If you don't have access to the min occlusion lens, you can actually put translucent contact paper or surgical tape over the glasses or the lens of the glasses, which effectively degrades the vision whilst allowing some light to enter through. Okay, the other option is you can make a patch too with micropore tape that you can put on glasses. You can also prescribe sector occlusion. This is just like sector prisms, where only a section of the lens will have an occlusive material over it. And you can either use things like micropore tape on this section of the glasses, or perhaps translucent contact paper, or even Bedlam tape, for instance, in these sections. Let's have a look at a patient with this. So here we have a patient who has sector occlusion, and there is a section of the glasses you can just see here, both on the right eye and both on the left eye, which has been occluded. So you can use Bedlam tape, you can use translucent contact, anything that will occlude that section of the lens. And in this particular instance, it looks like it's a translucent material rather than a full total occlusion that's been utilised. So the explanation here is that we have a patient with bilateral abducent paresis, so bilateral sixth nerve palsy. She has limited abduction on both sides, and we can see here she has a limitation in abduction here. So when the patient looks over right gaze, this particular sector occlusion will stop diplopia from occurring in right gaze. When she looks over to left gaze, again we can see limited abduction here, so she'll have diplopia. And in this instance, this sector occlusion here is stopping or preventing the patient from experiencing diplopia in that position of gaze. Again, for this patient, she has BSV in primary position, in which case we don't need to manage diplopia in primary position. Her complaint is in the periphery, in right and left gaze, and this is why we're using sector occlusion to deal with the complaint of diplopia in right and left gaze. The other option is to prescribe orthoptic treatment, and in this instance we're trying to utilise exercises to increase the patient's potential to achieve BSV. You would prescribe exercises such as fusion exercises. So for instance, if you had a patient who had a deviation in prior position and you note that their fusion range is reduced, you could provide a Fresnel and then increase their fusion range and try to reduce the size of the Fresnel slowly, with the patient regaining control of the deviation on their own through their fusion divergences. So go back to your concomitant deviation notes in relation to orthoptic exercises, as all of those that we've taught you are options, but fusion exercises tend to be probably the most commonly prescribed in relation to incompetent strabismus. Clearly, it won't be an option for all patients. If you have a large deviation, the fusion range may not be, or you may not be able to extend the fusion range enough to be able to take control of a large deviation, in which case those patients may need other treatment options provided to them. There is some debate also over the value of active version induction exercises, so trying to exercise the paretic muscle, because there is little evidence to suggest that by doing these types of exercises repeatedly, whether that would improve the function of the extraocular muscles. Generally, they're not prescribed with such little evidence, so rarely will you see those sorts of exercises prescribed by orthoptists. Okay, our final option is Botox, and Botox is sometimes given as a non-surgical management, and this will be done by the ophthalmologist. Most commonly it's prescribed for sixth nerve palsies, but can be prescribed or can be injected into any of the extraocular muscles. And most commonly it's injected in the ipsilateral antagonist, so we're looking at the muscle that has the contraction. And as you'll be aware from last semester, it blocks the conduction of nerve impulses to the muscle, so we will have a paralysis of the muscle we inject. So you can imagine if you're injecting that ipsilateral antagonist, that what will happen is that the eye, say for instance in the sixth nerve palsy, the lateral rectus is palsied, the medial rectus is contracted, the medial rectus will be injected. And what will happen is that that patient, which will have an esotropia due to the contraction of the medial rectus, will have the eye slowly move towards central position, and the aim will be that they would achieve BSV in prime position. Some studies suggest that by Botoxing the medial rectus or the contracted muscle, you may prevent contraction or mechanical restriction that can occur through long-standing contraction, but the jury is out as to whether that is effective or not, and there are ophthalmologists who do not inject for the purposes of preventing contraction. Now, Botox is temporary, so the effect can vary between patients, and generally they may start to lose the effectiveness of the Botox between 4 to 8 weeks. Some patients may have up to 3 months of effectiveness of the Botox treatment. Now, here's a list of benefits to giving Botox to a patient, and some of the things that we can see here is obviously you're going to reduce the size of the deviation. The patient may achieve BSV with Botox. If you don't achieve BSV, then they may be able to use a more comfortable abnormal head posture with the Botox. And one of the good things about it too is that you could have a trial run in terms of what might be the outcome from surgery. So you can show the patient using Botox what may likely be the outcome of surgery. And sometimes it can be effective in assisting a patient to lock into fusion after the Botox wears off. So the patient's had a reduction in the size of the deviation, they've been fusing for a period of 8 weeks, 9 weeks, etc. Recovery is occurring during this period, and as the Botox wears off, they may be able to maintain fusion post-Botox. So there's a few or several benefits to prescribing botulinum. There are also some adverse effects for you. You can't monitor recovery when the Botox is in. You actually won't have the opportunity to see what the change or the true change of the deviation is, because the patient has had an injection into the ipsilateral antagonist. We have variability in the time it lasts, and you won't know for each patient how long the Botox will last. So this could be an issue in terms of symptom alleviation, and then the other potential is leaking into other muscles. So if the Botox leaks into other muscles, say the levator for instance, the patient will have ptosis, or you could actually induce a deviation if you inject a muscle that you didn't want to, or you have leakage into a muscle that was not intended to have Botox. Let's move on now to the surgical management of patients with neurogenic palsies, and in particular the principles around surgical management of these patients. Now, as I mentioned earlier, in relation to surgical intervention, it is only indicated when you have waited at minimum 6 months and the condition has become static or stable. So if at 6 months it's still changing, you must continue to wait for stabilisation before surgery is indicated. Now, the aim of surgery is clearly to eliminate the deviation in primary positions and in most other positions if you can, and to give patients BSV where possible. So in these instances, we'll have a functional outcome if we're able to achieve BSV. If not, we'll have only a cosmetic outcome. In terms of principles of surgery, there are a couple of overarching principles we can utilise when managing a patient. And generally you can either operate on the affected eye or the unaffected eye, or both in some instances may be warranted. So let's take an example of a right lateral rectus palsy. So we have a weak or a palsied lateral rectus of the right eye. One of the options is to strengthen or perform a strengthening procedure on that lateral rectus. Okay, if it's totally paralysed, then a strengthening procedure is not going to be effective, and we perform transpositions in this instance. We'll talk more about transpositions a bit later. Okay, the other option is we could weaken the medial rectus or the ipsilateral antagonist of the right lateral rectus to gain improvement in the deviation. Okay, another option is to move over to the unaffected eye, and most commonly when we go to the unaffected eye, the muscle that will be operated on is the yoke muscle, so the contralateral synergist, and in this instance it would be the left medial rectus that would be operated, and this would be weakened. It's an overacting muscle often, also, so that makes sense that you would be weakening that particular muscle. So what factors influence the choice of surgery? There are a number, and all of these will be taken into consideration when determining what operation to proceed with. So one of the main things to look at is where you have a neurogenic palsy, is the muscle completely paralysed or does it have some function? So as I just mentioned a moment ago, if a muscle has some function, then you can perform strengthening procedures on that muscle, such as a resection. However, if there is totally no function, trying to strengthen that particular muscle by doing a resection will not work. And in these instances, there must be transposition of adjacent muscles to the affected muscle. The other thing we'll want to know is it relatively concomitant, or is there a direction of gaze that the deviation is greatest? Let's take the example of the right lateral rectus palsy I was just talking about. In that instance, if the deviation is relatively concomitant, it is an option to recess or weaken the medial rectus of the right eye and resect and strengthen the lateral rectus of the right eye, which will have an impact both in right and left gaze, because the lateral rectus of the right eye is used in right gaze, the medial rectus of the right eye is used in left gaze, and will have a relatively better impact on a concomitant deviation. If, however, the deviation was greatest in right gaze, then the option may be to not go for the medial rectus of the right eye, but rather to operate on the lateral rectus of the right eye and the yoke muscle, the medial rectus of the left eye, in which case you're going to have a greater impact in right gaze, or the surgery you perform will have, or that the surgeon will perform will have a greater impact on right gaze. So that's just an example of how size of deviation and its change in various positions may impact on the surgical choice. Okay, the presence of horizontal and vertical components of the deviation will influence whether vertical muscle surgery is performed or horizontal muscle surgery is performed, or a combination. We also have the consideration of the cyclotropia. If a patient has torsion and torsion is preventing fusion, then one of the considerations is to do specific surgery for torsion. And we'll talk about this more when we get to fourth nerve palsies, where this is particularly an issue. Okay, the presence of large AV patterns. If there is a large AV pattern, the surgeons will need to address the pattern, and surgical options may alter dependent on this. The size of the deviation in primary position will be a factor as well, as this will determine the amount of surgery required and sometimes the number of muscles that need to be operated on. And finally, the result of the FDT. So looking at whether there is a restriction, such as contraction and FDT, a result may change the surgical decision based on a positive FDT. At this point, I would like to mention that one of the complications of strabismus surgery, although it's rare, you should be aware of, is anterior segment ischemia. Now, anterior segment ischemia occurs when multiple rectus muscles have been detached from the globe, and as such there's been an interruption to the vascular supply of the anterior segment. Now, in severe cases, this can cause permanent damage to the eye and vision from a variety of things such as cataract, corneal scarring, and retinal or macular changes. So where performing strabismus surgery, it is recommended that, where possible, to do no more than 2 rectus muscles, or perform a procedure on 2 rectus muscles. And if the 3 muscle surgery is performed, to perhaps leave one of the vertical muscles, superrectus or the infrarectus, or to not detach the medial rectus, as these are the 3 muscles that provide the major anterior ciliary blood supply to the anterior segment. So just be aware that performing surgery or performing strabismus surgery and detaching the rectus muscles can have an impact on blood supply to the anterior segment, and this needs to be considered by surgeons as they elect or select to do particular operations. So here we have a list of a variety of weakening, strengthening positions that can be performed and transposition operations that can be performed. When we get to talking about the management of various neurogenic palsies, I'll come back to these procedures, and where possible I'll provide you a video with some of the relevant procedures undertaken. Okay, another thing to note before we conclude is that with adults, adjustable sutures are also an option, where adjustable sutures can be used, and post-operatively the position of the eye can be adjusted. So where appropriate, this is also a consideration in managing neurogenic palsies. Okay, so overall, if a patient presents to you with a neurogenic palsy, particularly if they're of recent onset, you will need to monitor the patient for spontaneous recovery and for stabilisation of the condition. So at minimum, you will be waiting 6 months in terms of monitoring the patient before you consider any other treatment options, specifically surgery. Now, you need to communicate this to your patients and inform them that you're monitoring the deviation, and you're managing their symptoms in the interim, and that what their other options may be later down the track if there isn't improvement. Okay, in terms of managing the patient's diplopia, as we've discussed, there's a number of options we have. The patient could utilise an abnormal head posture, or they could be taught to move their head instead of their eyes where they have diplopia in the periphery. We can prescribe prisms. Now I've got framal prisms here, but if you need a long-term solution, you can ground them as well as required. You've got occlusion that you can prescribe, and again, this is not a preferred option because you're taking away BSV. The abnormal head posture and the frenals provide patients with BSV. Occlusion takes away any capacity for the patient to utilise binocular single vision, and therefore it's not a preferred option unless you have to go down that road. And again, there's a plethora of options in regards to what type of occlusion you offer the patient, as there is with frenals in terms of whether it's complete sector or segmented. Okay, and we also can provide orthoptics or exercises where required, and Botox is an option in terms of a non-surgical method of managing diplopia. After you've waited a minimum of 6 months, or at the point at which you've noted that the deviation is stable and the condition is no longer changing, it's static, surgical intervention can be considered. And there are a number of factors that will determine the surgery of choice, and we'll talk a little bit more about this as we go more specifically into the various neurogenic palsies that a patient may present with. Okay, that brings us to the conclusion of this video. Thank you for watching.